Sir, we are live now. You can start by introducing yourself.
Yeah, one second. Okay. Shall I start?
Yes, sir, you can start.
Hello, friends. Yeah, I'm Dr. Karthikeyan, consultant gastroenterologist from Coimbatore, and I'll be talking today on irritable bowel syndrome. Before that, I want to thank the organizer for having such a wonderful Zoom meeting so that I could address a lot of my fellow doctors and share my ideas with them on monthly basis. Probably this will go on every month with different topics of your interest. Probably we'll covering the entire gastroenterology and some even more than that. And it'll be more of an interactive thing. So I'll complete my presentation. After that, be adequate time for you to ask questions so that we could discuss and then we could find some answers for that. So it's a learning process for me also. So I go into the articles, textbooks, the recent um, guidelines, etc., before preparing this talk. So it will be really wonderful for both for me as well as for the listeners. So we'll enjoy the session. So we'll go to the session right away. Okay. Today I'll be talking to you with the very common practical gastrointestinal problem, the irritable bowel syndrome. Can you, Saurabh, can you share this slide, please?
Yes, I will share this slide. Yeah. Yeah, I'm making it full screen. Yes.
Yeah. So this is irritable bowel syndrome, one of
Sir,
the
are the
very
slides
common.
visible?
Yeah, it is visible.
Okay,
Yeah,
sir. Just let me know when I should change the slide.
yeah, you could slide. Change the slide, please. Next slide, please. So irritable bowel syndrome is one of the commonest gastroenterologic symptoms, and even for the GP, it is one of the very common symptoms that one could encounter on daily basis. People come with variety of spectrum of illness like abdominal pain, bloating, alteration in bowels, loose stools, constipation, or sometimes altering loose stools and constipations, gas in the abdomen, gas, eructation, postprandial fullness, all may comprise the spectrum called as irritable bowel syndrome. It is not a disease per se, but it is a constellation of symptoms given this name for better identification and management. Next slide, please. Saurav, please change the slide.
Sir, already changed the slide. It's wrong criteria.
No, it is not. It is not there. I couldn't see that. I could see only the first slide.
You're not able to see the slide?
No, only first slide. One second.
It's a wrong 3 criteria slide now.
No, no, I want definitions criteria. Definition slide.
This one?
Definition slide. The definition slide.
Definition slide.
Yeah, and now I'm seeing. The first slide I'm seeing again.
Yes, this is a definition slide, sir.
Are we in the definition slide?
Yes, sir. This is definitely functional GI disorder.
Okay, but I'm not able to see it.
Now you can see the slide, sir.
No, I'm not able to see. I can see your name only.
You're not able to see the slide.
No.
So I will just reshare it once again.
Yeah. Got it.
Yeah.
Yeah, got it, sir.
Yes, sir.
Yeah. So irritable bowel syndrome, by definition, is a functional GI disorder. We have a classification of functional GI disorder. A lot of diseases come under this classification of functional GI disorder, like achalasia cardia, small intestine motility disorders, defecation disorders, etc. And IBS forms a central part of all these disorders. So it is defined as a functional GI disorder in which the abdominal pain or discomfort is associated with abnormality of defecation or change in the bowel habits. So two things should be there. There should be an abdominal discomfort or pain associated with bowel movements. Okay, there will be increased bowel movements or decreased bowel movements or alteration in the previous normal pattern bowel movement. Okay, all can comprise IBS. But this criteria is little bit uh, abstract, isn't it? So we don't have a cutoff for what is normal, what is abnormal, what is discomfort, and what is pain. It varies with people, varies with the people of different economic class, social class, race, religion, ethnicity, etc. So these criteria are constantly modifying to make it better in identifying these patients. Okay, it has undergone 4 modifications since 1989, the time when it was first proposed in a group of people. And the first criteria was called as the Manning criteria. And after that, the Rome criteria come into being, Rome 1, 2, 3, and currently we have the Rome 4 criteria. Next slide, please. Yeah. So the supportive symptoms for diagnosing IBS are abnormal stool frequency, either the low frequency or high frequency stools, either diarrhea or constipation. 3 or fewer bowel movements per week, or more than 3 bowel movements per day. Both comprises of this definition. Abnormal stool forms. The stools can be once per day, but it could be abnormal in terms. It could be liquid stools, semi-solid stools, or very, very hard, difficult to evacuate stool. So all these can be abnormality in passing stools. Loose or watery stools, urgency or incomplete bowel movement. People may complain of incomplete bowel movement. The moment I completely pass the stools, the moment I come out of the bathroom, I still feel that something is left and I want to go back again. This is a common complaint people used to tell. These are also a part of abnormal defecation process. Passing of mucus or bloating all may come under abnormality in the abdomen, abdominal distension, abdominal bloating, etc. So these symptoms have to be there to classify them as irritable bowel syndrome. Next slide. So from Manning to Rome, we have Rome 4 criteria. So Manning, Rome 1, 2, 3, and currently we have 4, Manning 4, sorry, Rome 4 to define this symptom. Okay. Rome 4 recently been published 2017, and it replaces the abdominal discomfort by pain. Okay, which can happen even at least once per week. Next slide, please. We'll see the difference between Rome 3 and Rome 4. Okay. Rome 3, this is a Rome 3 criteria for definition of IBS. This is particularly useful in having a survey of people who are suffering from IBS in a community. We can apply this criteria and diagnose IBS in a community. Okay. For a hospital setup, this stringent criteria may not be adequate or may not be useful, but still in a broader scientific paper or for a community kind of surveillance, these Rome 3 criteria, Rome 4 criteria can be most useful. Recurrent abdominal pain or discomfort at least 3 days a month in the last 3 months associated with 2 or more of the following: improvement with defecation, onset associated with change in the frequency of stool, onset associated with change in the form of the stools. So 3 things should be there. 1, the patient should have discomfort, pain or discomfort for 3 days a month. So at least 3 days a month for last 3 months. So the symptom should be chronic. At least 3 months, the patient should be suffering at least 3 days a month. Okay. What are the symptoms? There should be abdominal pain or bloating. It should be associated with some amount of defecation problem, like associated with change in the frequency or stool form. Okay. So abdominal pain or bloating with change in the stool frequency or stool form. This comprises of IBS as per Rome 3 criteria. There is a small kind of abstract in this because abdominal pain or discomfort is a vague term. Some people may have abdominal pain, some people may have discomfort. Some people may not be able to particularly say whether they have pain or discomfort or both. Sometimes they may be pain, sometimes they may be discomfort. Even lactose intolerance may have abdominal bloating associated with diarrhea. So there can be false positive in applying this criteria. Also, there is a class called as improvement with defecation. So most of the people may have improvement after passing stools. The abdominal pain subsides after passing stools. This was taken as a criteria previously, but now that we found that there are small group of people who had worsening of symptoms after passing stools. The abdominal pain becomes very severe. Patient has to take some medicines or lie down on the couch to relieve this pain, or apply some peppermint oil over the abdomen, or tap the abdomen, something like that. Or some people may have severe bloating following defecation. So next slide, please. Rome 4 criteria accommodated these findings and came with a revised criteria. So it goes like this: recurrent abdominal pain, an average 1 day per week. So instead of 3 times a month, it is 1 day per week. So 1 day per week for the last 3 months. 3 months is the same. So at least 1 day per week, patient will have some symptoms associated with 2 or more of the criteria, like related to defecation. It can either become better or worse with defecation, but there is some association with defecation. The pain either worsens or become better after defecation, and should be associated with change in the frequency or with the form, just like the Rome 3 criteria. Now we have little decent criteria to apply in the day-to-day practice. Okay. So patient should have at least 1 day per week symptom. The symptom should be abdominal pain, not distension, and it related to defecation. The defecation problem should be either frequent alteration frequency or alteration in the form. Next slide, please. Okay. So this was the previous criteria we used to study during our college days. The Manning criteria, where the principal emphasis was on the abdominal distension or abdominal pain, which eased after bowel movement, feeling of incomplete emptying, looser stools at the onset of pain, or more frequent bowel movements at the onset of abdominal pain, or mucus per rectum. These were the criteria taken as per Manning proposal. And after that came Cruise criteria, where patient history and physician assessment was predominant. The emphasis was on the history, like abdominal pain, flatulence, bowel movement abnormalities, fixed diarrhea and constipation, pellet-like stools or mucus in the stools, symptom more than 2 years. Whereas physical assessment, like general global assessment, nutrition assessment, etc., abnormal physical findings rules out IBS. ESR more than 20 rules out IBS. Hemoglobin less than 12 in males and 14, 12 in females and 14 in males also needs evaluation before terming them IBS. History of blood in the stools, leukocytosis, all goes against the diagnosis of IBS. These were the previous criteria. Now we don't have any clinical criteria or laboratory criteria. All we have is a criteria from the history alone. So any paramedical person, physician assistant can apply this criteria and come to a reasonable conclusion of IBS. Next slide, please. This is a Bristol stool scale. Every gastroenterologist or a physician should have it in their desktop, in the desk. This is a patient assessment of the stools. Okay. So type 1 up to type 7 type of stools are there. Type 1 is very hard pellet-like stools, very hard to pass. And type 2 is a sausage sized shaped stool, which is little bit lumpy and little bit hard to pass. Type 3 is a little sausage, but still can crack on the surface. Type 4 is like a sausage, but smooth and soft, easily passed. Type 4 is soft blobs like without any clear-cut edges. And the sixth is a fluffy with ragged edges, a mushy stool. And the type 7 is a complete watery loose stools. Okay, watery stool. So these are the stool forms, and the patient can visually see, and then he can tick on the boxes that closely resembles the patient's stools. Next slide, please. So basically, IBS is diagnosed with abdominal pain, and there is some association with defecation, either constipation or diarrhea. May not have non-colonic symptoms, and there should be chronicity of at least 3 months duration. Next slide, please. Okay, there are subtypes of IBS. We call them subtypes, and it is called as IBS-C, IBS-D, mixed IBS, and unsubtyped IBS. So IBS-S have predominant constipation. IBS diarrhea have predominant diarrhea. Mixed have waxing and waning of both the symptoms, diarrhea and constipation. And unsubtyped IBS may not have this diarrheal symptom, but may eventually get into one of these subtypes. Next slide, please. This is a graph showing the bowel movement and the subtypes. So the percentage of people with hard and lumpy stools, if it is more than 75%, we call them IBS-C. And if the percentage is less than 25 and the movements are more of watery, loose, we call them more of IBS-D. And there are variety of other forms in between these two, IBS-U, IBS-M, etc. Next slide, please. This is a bloating as per X-ray. People have a physical distension of abdomen, whereas X-ray showing air locking in large intestine at some of the points, making it more and more distended, anteroposterior distension, as well as the distension of the individual colon also. Next slide, please. So social impact of IBS is huge because it is the most prevalent GI disorder. And 12% of visit to the primary care physician is IBS, and it comprises of 40% of visit to gastroenterologist. And people used to come to gastroenterologist very frequently, even once a week, twice a week, etc., or come in the midnight with abdominal pain to the emergency, and it stresses a lot for the patient, family, as well as the healthcare giver. So the lot of phone calls to the doctors, lot of phone calls to the relatives, and etc. All are because of the flares of IBS. Okay, so it has a huge impact over the society as well as to the individual. Seventh most common diagnosis arrived at OPD, and it has significant healthcare cost, disability rates, as well as work absenteeism. Next slide, please. What is the pathology behind IBS? Why it happens? It has been conventionally thought that IBS doesn't have any pathology. All is there in the mind. It is not true. All is not in the mind. All people with IBS do not have mental disorder. Please be considerate to them, be sympathetic to them. So most of these people have normal mental capability just as anybody else. Okay. The factors predisposing to IBS are visceral hypersensitivity. What is visceral hypersensitivity? There is increased amount of sensitivity to the bowel movements as well as the bowel contraction than the counterpart, than the normal people. So this is called as visceral hypersensitivity. This can be easily understood. A person who has been stuck with a prick with a nail or pin or something. Some people may ignore it and then go on with their work. Some people may cringe over that and cry over that. So it depends on the personal capability of tolerating the pain. This kind of pain tolerance in the gut is called as visceral hypersensitivity. Okay. The hypersensitive they are to the bowel, the increased in the symptoms of IBS. Okay. So while treating IBS, we address this component, we decrease the sensitivity of the colon and the enteric nervous system, thereby people may get relief of the symptoms. Okay. So second abnormality is the connections in the brain gut axis. We know that there is multiple amount of neurons coming out of the enteric nervous system of the entire gut, and they are relayed in the brain. Okay, the gut and the brain have very close interactions with the back and forth movement of information. Okay, the gut can influence the brain, and the brain can influence the gut. So we know that during our exams, we have some kind of hunger pranks in the stomach. We have feeling of going to the washroom, or we had a kind of urgency or palpitation or burning sensation in the abdomen. So time and again, we know that if we have anxious or something, our appetite or our bowel movement get disorganized and will go haywire. Same kind. So when there is an abnormality in the gut, when there is some infection in the bowel or something, we find that we have there is a severe impact on the disease over the brain. People may get depressed. People may have increased anxiety, drowsiness, lethargy, etc., following some kind of abnormality in the gut. So the gut and the brain are completely um, connected, and each of the illness may be reflected on the other systems as well. And this is called as brain gut axis. There are a lot of pathology mechanisms and physiology regarding the gut brain axis. We'll talk about that a little later in the following sessions, one of the following sessions. There is abnormality in the neurohormonal factors. There is a difference in the fasting ACTH levels, corticotropic releasing hormone levels, 5-hydroxytryptamine levels, etc. These can increase the visceral hypersensitivity or per se when bring out problems of diarrhea or constipation. And other mechanism proposed are the alteration in the gut flora and dysbiosis. We know that our colon contains a multitude of bacteria. We don't know how many species of bacteria we have. At least there are 3,000 species of bacteria in our gut, and the number of organisms are in the trillions. And it has been said that we have more bacteria than the number of cells in our body. So actually, bacteria are the primary dweller of the body, and our cells are a tenant in the bacterial colony. That is how we can look at that in the other way. So when the bacteria population or the composition is altered, we call them dysbiosis. So when the normal pattern of bacterial colonies and the bacterial proportion, what I call the bacterial count and the variety of bacteria, both are altered, we call that dysbiosis. This kind of dysbiosis may lead to variety of illness. Now that a lot of more illness have been discovered because of dysbiosis of gut, and one of them is irritable bowel syndrome. In fact, 40 to 50% of people with irritable bowel syndrome are found to have small intestinal bacterial growth with dysbiosis. So this is again an important contributor to the symptomatology of irritable bowel syndrome. Food intolerance, as I told, lactose intolerance, fructose intolerance, all can contribute to the irritable bowel syndrome. Sometimes it is very difficult to separate fructose or lactose intolerance to IBS. Both may coexist, the symptom may overlap, and it may be very difficult to separate those two entities. Other mechanism proposed are the low-grade inflammation occurring in the mucosal membranes of the large intestine, and abnormality in the bile acid metabolism, abnormality in the tryptophan 5-hydroxytryptamine metabolic alterations, and some of the genetic factors which are yet to be proven. Next slide, please. These are overall mechanism of pathophysiology of irritable bowel syndrome. People have some kind of adverse life events which may contribute to the visceral hypersensitivity, anxiety states, or phobic states, which can lead to depression, hypochondriasis, etc. And the local inflammation in the gut and lymphocytosis, toxin, maybe bacterial toxin, etc., may have an adverse effect on the brain, which relays the information from the gut and may give rise to problems. Next slide, please. Yeah. This is a much clearer slide. The lower part, we can see that there is an alteration in the bowel because of the GI infection or diet and food intolerance. The alteration in the GI immune system, intestinal permeability, and mucosal inflammation, which give rise to dysbiosis and abnormal gas handling in the colon. This results in the abnormality in visceral afferent functions, and there is a abnormality in the regulation of gut function like motility, secretion, and 5-hydroxytryptamine metabolism. All these lead to abnormality in the central processing of information and in the brain, in the angulate cingulate cortex, and which gives rise to the irritable bowel syndrome like situation. The predisposing factor in the brain could be acute or chronic stresses, past life experience of bad experiences, etc. All the post-traumatic stress disorders kind of thing, all can contribute to the pattern of the irritable bowel syndrome, which other environmental factors can contribute and exacerbate. Next slide, please. This is an interesting slide. This slide is a result of the rectal balloon expulsion in patients in normal controls, patient with irritable bowel syndrome, patient with functional constipation, patient with functional dyspepsia, and others. Okay, so others means people with other diseases. So this is actually taken after a rectal installation of uh, um, rectal installation of balloon with various amount of pressure inside the balloon. So people will be subjected to rectal insertion of a small balloon, which is inflated with air. After a particular pressure, patient will be able to feel the discomfort or the pain. The exact pressure at which pain occurs will be noted. Okay. So controls will have pain at least at 40 millimeter pressure. Most of the controls will have the pain starting at 40 millimeter pressure at the balloon, rectal balloon. Whereas irritable bowel syndrome experiences pain even at the lower rectal pressure, rectal balloon pressure, even at 20 millimeter pressure, the irritable bowel syndrome patients experiences pain. Okay. Whereas people with functional constipation, they have roomy rectum and we have less rectal innervation. So they have little amount of pain even at beyond 50 millimeter mercury. And functional dyspepsia people have pain starting at more than 40, and miscellaneous people may have more similar to the controls. Okay. What this tells is that there is a visceral hypersensitivity, and the distension of the colon or the any viscera beyond a smaller point will cause some amount of pain or discomfort for patient with IBS, which is not seen in the controls. Next slide, please. Okay. Psychological factors. People with 80% of abnormal psychological testing. IBS people will have at least 80% abnormal physiological testing. All of them may not contribute to the mental illness, but have subtle changes in the psychological testing. Some of them may have major depression, generalized anxiety disorder, panic disorder, phobias, stress and adjustment disorders, major lifetime events like deprivation of parenthood or some abuse in the childhood, etc. So 20% of people have very significant history of any major psychological disease, but 80% may have normal life history. But when they are subjected to some psychological testing, they may show some subtle abnormalities. Okay, next slide, please. These are neurohormonal factors: vagal dysregulation, alteration in sympathetic or parasympathetic tones, visualosensory cardiovascular reflexes. There is abnormality in baroreflex, arterial baroreflex. So vasospasm or vasodilatation occurs with patients with IBS. Next slide, please. Exaggerated response to corticotrophin releasing hormone in the pituitary, in the hypothalamus, high plasma ACTH levels, high plasma pancreatic polypeptide, cholecystokinin, motilin, gastrin, neurotensin, all are neurohormonal hormonal proteins, also secreted in the gut. increase in the level of nitrous oxide in the myenteric neurons, the GIT, and increase in protease activated receptor 2, which is the final common pathway of the 5-HT receptor pathway. Next slide. Yeah. 5-HT, tryptamine is an important neurotransmitter of the enteric neurons. This is secreted by the enterochromaffin cells situated in the mucous membrane of the entire GET. The pancreatic polypeptide peak and high hydroxytryptamine all are high in post-infectious IBS. There is an abnormal ratio of 5-hydroxy acetic acid and 5-hydroxytryptamine, both from the common precursor, and there's a shift in the ratio of 5-indole acetic acid and 5-tryptamine in IBS patients. Next slide, please. This is a serotonin pathway, a 5-hydroxytryptamine pathway. 5-HT is secreted by the enterochromaffin cells of the mucous membrane, and it gets into various forms like 5-hydroxy isoforms, etc. And it is an important neurotransmitter in the myenteric plexus. It signals the enteric nervous system, which signals the central nervous system either for muscle contraction or for relaxation. It is contribution to the peristalsis of the GIT. Next slide, please. So other hypothesis will be low-grade inflammation. This is contributed by biopsies of patients with irritable bowel syndrome, shows altered lymphocytes, mast cell ratios, and pro-inflammatory cytokines in the mucous membrane of the colon in patients with IBS. This is not yet proven. There is no active inflammation, but still there is some amount of recruitment of lymphocytes. Some mast cells, enterochromaffin cells are increased. Some eosinophils are increased in mucous membranes in these patients. There's altered cellular immune responses and increase in the release of IL-6 and IL-1B. Next slide, please. Genetic factors. Lot of studies have thrown light into genetic factors in IBS. Still, we cannot pinpoint one gene responsible for irritable bowel syndrome. And nevertheless, there is no proof that IBS is transmitted in families. There's no Mendelian inheritance of irritable bowel syndrome. But still, there is some amount of light seen in abnormalities of G protein translation of ligand receptor C8257 and GN beta 3, which is increased in patients with IBS, in families with IBS. Next slide, please. Altered gut flora, I told you, 78% of people with IBS had small intestinal bacterial growth. It is tested by C14D-xylulose test and jejunal cultures. There is significant amount of lactose malabsorption, fructose, sorbitol malabsorption, and food allergy in patients with IBS. All can overlap. Next slide, please. GI infection. Past GI infection, will it contribute to IBS? There is a separate entity called as post-infectious IBS, which typically occurs following a GI infection. Typically, like Campylobacter, Salmonella, Shigella are more prone for development of post-infectious IBS. Patient may have symptoms of diarrhea after subsiding of GI infection for more than 6 months. Okay, there is increased amount of mucosal enterochromaffin cells, lymphocytes, low-grade inflammation persisting more than a year in these patients. Next slide, please. Next slide. Yeah, this is a common integrated model of IBS. There is a basic psychological factors, stress, lifetime events, etc. On top of it, there will be some amount of altered bacterial flora, past GI infection, abnormality in enteric nervous and autonomic nervous system and central nervous system, which contributes to the formation of irritable bowel syndrome. Next slide, please. So while assessing the patient with IBS, we have to be very mindful of this red flag signs. When patient brings out this red flag signs, we should be careful not to brand them as IBS. When the patient tells that he or she had blood in the stools, chronic diarrhea more than 6 times, 8 times per day, family history of colon cancer, IBD, celiac disease, etc., fever associated with fever, nighttime symptoms, symptoms that awaken the patient from the sleep. This is not IBS. Onset of IBS more than 50 years, we should be rethink and then go extensively to evaluate the bowel before considering them as IBS. Progressive dysphagia, vomiting, short history of symptoms less than 3 months, travel history to local endemic or some third world countries, weight loss, all may give suspicion that the patient may not have IBS, may have something else. Physical examination of an abnormal mass, presence of arthritis, skin changes, dermatitis herpetiformis for celiac disease, or pyoderma gangrenosum for irritable IBD, inflammatory bowel disease, or blood in the rectal examination, signs of anemia, intestinal malabsorption, intestinal obstruction, or thyroid dysfunction, all may give a clue that the what we are thinking of IBS may not be true. It may be something else. Next slide, please. So diagnosis IBS is straightforward. Patient of chronic symptoms, typically coinciding with the criteria that we have seen. Obtain good history, perform physical examination, including medical, surgical, and delivery history. Digital rectal examination to find out any stool, blood in the stools or mass in the rectum. If physical examination is normal, no warning signs in the history, apply Rome 4 criteria, and they get a positive diagnosis of IBS. Next slide, please. Consider limited testing confined to complete blood count, CRP or ESR level, celiac serological testing, fecal calprotectin to detect irritable bowel syndrome. An ultrasound or a CT abdomen will suffice. Okay. If the patient has some amount of red flag signs, we go extensively, taking good history and completing a colonoscopy or a CT scan abdomen to rule out any GI malignancy, etc. Use Bristol school form scale to identify IBS subtypes. We have seen the Bristol stool scale, which can be used to identify the subtypes of IBS. Initiate treatment based on the predominant symptoms. So, get a good history, do a complete physical examination, rule out alarm signs, apply Rome 4 criteria, we get a positive diagnosis of IBS. Limited investigation can be used to find out any coinciding diseases. And if it is negative, you have a positive diagnosis of IBS, we treat them accordingly after subtyping. Next slide, please. Okay. General treatment guidelines for IBS, lifestyle changes. People who are anxious or we have some phobic kind of thing has to be given some kind of support, counseling to change their lifestyle and to make them live happily, healthily, without any anxiety. Education about the disease and counseling is particularly important, which is necessary every time the patient visits the doctor. Okay, every time they need some amount of counseling. They may not need medicines, they need some amount of reassurance and counseling. Always you dissolve the misconception of the patients with IBS and go for clarity in the knowledge. Okay, these patients have a lot of misconception, either gathered from internet, social media, friends, families, etc. And every time they come with some amount of misconception. Will it go on developing a cancer, sir? Will this cause kind of ultimately lead to surgery? Will I live longer? Will I live enough to see my child getting married? Something like that. Okay, every time we need to reassure the patients and we bring about clarity in the diagnosis and things about the disease. Okay, we can ask them to connect to a website or something, or a development of a group with similar kind of misconception, so that we can have a group meeting and we can address their concerns during the group meetings. Okay. Caregiver is very, very important. The doctor can be caregiver, but still a proper caregiver can be identified within the family so that they can, smaller symptoms can be taken care by them. Okay. Anti-anxiety strategy can be very, very useful in patients with severe anxiety kind of symptoms. Always don't repeat testing every time the patient comes. It will lead to increase in anxiety because doctor also feels something is missing with me. So it brings more suspicion in the patient, and the response of the treatment may not be good. So always do testing only when necessary, when the patient have different kind of symptoms than the usual symptoms. Okay. Suppose the patient comes with fever, a known case of irritable bowel syndrome, you can do some testing. Not for the same symptom which used to come repeatedly. Okay. Group therapy, which I told you, is particularly useful in allaying their misconception and dissipating recent knowledge about IBS to the patients. Community is very, very important. If it's a possible, we can group them in the community with a social media or WhatsApp or something. They can share the experiences. They can learn by sharing the experiences. This is very good because otherwise they can get a lot of false information from people outside. So always it is better to share things and then get clarified within their community. Diet counseling is very, very important. Dietitian is a central role in irritable bowel syndrome, and each patient has a different dietary needs and dietary tolerance. So everything should be addressed on individual basis. Next slide, please. Okay. Strategies could be use of laxatives for patient with constipation, bulk forming agents for patient with constipation, antidiarrheals for patient with diarrhea, serotonin receptor drugs for patients, all kinds of patients, all receptor for patients, anxiolytics, antispasmodics, antidepressant, probiotics, antibiotics, alternate medicines, or psychological therapies. All can come into play in different stages for patients with IBS. Next slide, please. Okay, this is a food map diet. This is of recently there is a lot of interest in the food map diet, which reduces the symptoms of IBS in a lot of patients. These are some of the drugs which have low food map, fructose, etc. And low fructose containing diet have better symptom relief in patients with IBS. Yeah, you can take a lot of lettuce, carrot, cucumber, strawberries, chicken, eggs, etc. Oil, butter, peanuts. Less of garlic, beans, onion, blackberries, sausage, almonds, avocado, beans, wheat products, etc. So the lower thing are high food map diet, and upper one is low food map diet. Low food map diet has excellent tolerability in patients with IBS and can be given suggested for people for refractory symptoms despite medications. Next slide, please. Treatment of bloating can be initial step could be adjust diet, treat constipation, and the second step could be using of probiotics, non-absorbable antibiotic like rifaximin or tricyclic antidepressants or SSRIs. For constipation, we can start with fiber supplements, and if not working, we can consider lubiprostone, linaclotide, and flecainide. For diarrhea, loperamide or 5-hydroxytryptamine antagonist like alansetron can be used. For abdominal pain, we can use an antispasmodic or in severe cases, tricyclic antidepressants or SSRIs can be used. Next slide, please. Certain amount of non-pharmacological interventions are also very, very useful in patients who have severe symptoms or people not responding to medications. Hypnotherapy is very, very, very handful in patients with phobias and other things. Cognitive behavioral therapy is useful for people with OCDs and compulsive disorders and severe anxiety disorders, etc. It can even be effectively given over the internet or Zoom, etc. Soluble fiber can be tried with patients. Soluble fiber, high dose of fiber can be tried with patients with constipation. Low food map diet, which I have already told. Exercise like aerobic exercise, swimming, walking, etc. reduces symptom by more than 50% of people. So we can advise them do an exercise without any pharmacological intervention. Probiotics, natural available probiotic can be helpful in addressing diarrheal kind of illness, and it is also useful in certain patients. Next slide, please. Yeah. Yeah. These are some of the new drugs are there, which are also very useful. One is the chloride channel activators like lubiprostone, which activates the chloride channel in the large intestine and relieve symptoms of constipation. This is quite useful. Up to 25% of people has reported improvement in symptoms like nausea or diarrhea, and absolutely safe profile. Guanylyl cyclase antagonist, GMC antagonist like linaclotide or plicanide are useful for patient relieving constipations, which is not available in our country. SSRIs are useful in patients with severe pain with depression, etc. Rifaximin is useful for people with diarrheal illness. It alters the bacterial overgrowth and also useful for people with bloating and the mixed type of IBS. 5-hydroxytryptamine antagonists like ondansetron are useful for controlling diarrhea. But the problem with ondansetron is it can cause some kind of ischemic colitis in severely constipated women, and it should be avoided in females. Opioid receptor drugs like eluxinadol and loperamide. Loperamide is available in India, whereas eluxadoline is not currently available, and this can result in reduction of symptoms of diarrhea. There are reports of sphincter dysfunction, biliary type of pain, pancreatitis, etc. with the drug, and people with alcohol dependence may need higher dose of drugs to have effect. Tricyclic antidepressants are regularly used in patients with phobia, anxiety, pain, insomnia, etc. And common side effects are dry mouth and drowsiness. Antispasmodics also have similar kind of blood vision because of their effect on the parasympathetic nerves. Peppermint oil is quite safe and can be applied even over the abdomen or can be taken inside. Next slide, please. Yeah, these are some of the emerging medications in treatment of IBS. We have calcium channel inhibitors in terms of pregabalin and gabapentin, which we used to use for last 10 years. It reduces the pain in the pain predominant IBS, improves pain scores, increase rectal compliance, and discomfort and bloating. Drugs targeting visceral hypersensitivity. As I told you, visceral hypersensitivity is an important pathophysiological mechanism for pain in the IBS. And SSRIs are very good drugs for reducing pain and hypersensitivity. And these inhibitors, the code named LX1031, has shown positive in phase 2 trials, and phase 3 trials are undergoing. CCK, cholecystokinin 1 antagonist like dexloxyglumen is currently available in the United States for IBS constipation, which induces cholecystokinin and increased bile salt absorption and increased bowel movements. And currently, this is not available in India. Drugs targeting motility, like neurokinin 2 receptor antagonist, like ibodutent, it will be coming in India next year. And 5-HT4 agonist like velucetran, pruclopride is available in India, and naropride, which is the next congener of pruclopride. This is very effective in relieving constipations and abdominal bloating. Drugs targeting inflammation like master inhibitors like ketotifen and ebastin are promising, and we used to use with people with little bit of post-infectious IBS. 5-ASA, mesalamine, can be used in patients who have suspicion of microscopic colitis or irritable bowel syndrome. Drugs acting on ion channels like sodium hydrogen exchange inhibitors like tinaprinor is useful in relieving abdominal pain, bloating, and cramping. Bile acid modulators like covicelum and colistipol, which we used to use for people who have increased calcium, etc. And these can be used in patients with IBS. Yellow bixobat is a bile acid transporter inhibitor, which can be effectively used in people with constipation. And bile acid like quinodeoxycholic acid, obeticholic acid, all can be used in patients with IBS. Okay, but these things have not been approved officially, but people use it to relieve their symptoms. Next slide, please. So, so people with psychiatric overlap, severe psychiatric illness may have help from psychiatrist like psychotherapy, hypnotherapy, or cognitive behavioral therapy. All these things combined with medication as well as diet and counseling may give excellent release and new lease of life for these patients. Next slide, please. Okay, so we are done today with IBS. You have any questions regarding IBS, the diagnosis, Rome 4 criteria, and the management? So I'm willing to discuss about that.
Hello. Hello.
Hello. Yeah.
Yeah, sir. There are some questions are there. I will just
please.
put them in the chat.
Can you read it out or chat box? Chat. Okay.
I'm posting the questions. I'm posting the questions.
Okay. Yeah. Yeah, what is the pathophysiology of visceral hyperalgesia and Bowel syndrome? As I told you, it is primarily because of the abnormality in 5-hydroxytryptamine metabolism, and 5-hydroxytryptamine comes in several forms, and 5-hydroxytryptamine 1, 2, 3, and 4 each have different receptors. And when there is an abnormality in the receptor, or when there is an abnormality in the production of 5-hydroxytryptamine in the intrachromaffin cells in the mucous membrane, there will be abnormal processing of the bowel movement happening. This gives rise to abnormal transmission of these events to the enteric nervous system and to the hypothalamus. So when these kind of things are relayed, so the perception of people with irritable bowel syndrome over normal bowel movement will be perceived little differently, either with bloating or with pain. So the basic mechanism lies with predominantly with the 5-hydroxytryptamine metabolism in the intrachromaffin cells of the mucous membrane.
So we have one more question.
Yeah. What is esophagoduodenoscopy or colonoscopy indicated in the diagnosis? Yeah, colonoscopy is indicated in irritable bowel syndrome before Rome 4 is applied. If the patient comes with the symptoms typical of irritable bowel syndrome and we have the red flag signs ruled out, we get a positive diagnosis of irritable bowel syndrome. If some of the red flags are positive, the patient is older than a typical IBS patient, or patient had history of blood in the stools, significant weight loss, diarrhea happening in the middle of the night, or patient have fever, arthralgia, etc. We go on investing in the patient to rule out other colonic diseases that can closely mimic irritable bowel syndrome. One of them is colonic malignancy, and other is IBD, inflammatory bowel disease. The two can be excluded by doing a colonoscopy. Normally, any patient with more than 60 years presenting for the first time with IBS, we don't diagnose them with Rome 4 criteria. Instead, we do complete routine investigations like complete blood counts, ESR, CRP, etc., and subject them for imaging like ultrasonogram or CT, and completing them with colonoscopy. So any patient with more than 60 years, first time presenting with alteration bowel, think of colonic malignancy and we'll do a complete colonoscopy. Upper GI scope is indicated only if there is an upper GI symptom like regurgitation, heartburn, abdominal bloating following food intake, postprandial fullness, postprandial um, um, postprandial bloating, or vomiting, or blood in the vomitus. All these things indicate need for upper GI endoscopy. Or antidepressants effective in the treatment of correct. Yeah, antidepressants are very effective in patient treating IBS, particularly if the patient have overlapping anxiety, phobia, or depression. Okay, a simple IBS patient with little bit of alteration stools may not really benefit with antidepressants, but the patient with a considerable amount of anxiety or depression occurs. So these are the patients who need to be put on antidepressants so that they have better quality of life. What are the evidence-based recommendations for the use of inactulide in irritable bowel syndrome? Inactulide can be used in irritable syndrome in IBS constipation patients, and this is a very good drug to decrease the abdominal bloating, cramping, etc. But currently it is not available in India. Maybe we can get it later in this year. What are the ACG recommendation of management of patient? What I told you. So this is taken from the ACG guideline only. So we start with counseling, diet, behavioral modification, basic non-pharmacological treatment like counseling, psychotherapy, physiotherapy, etc., exercise, etc. Move on to fiber or dietary interventions. And when it is not working, we give antispasmodics, antidiarrheals, etc. And still it is not working, we move to tricyclic antidepressants or SSRIs. And if it is still there is an overlap of psychiatric illness, we ask the help of psychiatrist to go for CBT, hypnotherapy, or psychotherapy. This is a stage by stage treatment for irritable bowel syndrome as recommended by the ACG. Thyroid tests are done as a basic test for irritable bowel syndrome after completion of Rome 4 criteria.
Hello.
Hello. Yeah.
Yeah, sir. All the questions are done. Yeah. And thank you very much, sir, for your valuable time and sharing the
Thank you.
topic.
Yeah, we'll come back to next month with some other interesting topic. Okay. For them, we'll have more discussions on that.
Okay, sir. No problem, sir. Yeah.
Thank you.
Thank you, sir.